Good evening, my brothers and sisters. Today we are meeting on the second webinar, which is a very interesting subject, WHO guidelines, stage 1, stage 2, stage 3 treatment and the preferred drugs. Last week, we had a very good program on diagnosis of hypertension. I think I will continue with the last meeting summary also, because every time before the second webinar, the first summary will be given. Now, yeah. Can you see the slides, please?
Yes, sir.
Okay. Yeah. World Lung Foundation South Asia is a main aim is to the areas of public health ranging from cardiovascular disease control and prevention to road safety to environmental health to civil registration and vital statistics. All public health related activities and the scope of the work cover comprehensive public health services. So we are very happy to join with World Lung Foundation who are interested in public health activities. Of course, all of you know about Whole Medical Academy. Now, the objectives of this masterclass webinar series is to promote standardized care for hypertension that is evidence-based and aligned with international best practices. The focus of the virtual workshop would be to promote standardized care for hypertension-based recent WHO hypertension treatment guidelines, to promote opportunistic screening of all patients over the age of 18, to reduce physician inertia to start and continue treatment of hypertension, to emphasize the importance of medication, titration and follow-up of hypertensive patients to ensure better blood pressure control. These are the webinars which we are going to do. The first one we already done. Second is today. The third on 1st July, engagement of private sector in hypertension treatment and control. Today's the panelist. The speaker is my good friend, Dr. Prabhakar, is a cardiologist from Chennai, who is also incidentally the organizing treasurer for the incoming CSA conference. He has written a lot of articles and he has given orations and speeches in various forums. And my good friend Sadan Sethi, a cardiologist from panelist from Bombay, is not only good in the subject, he's also good in spiritual wisdom and sharing non-medical knowledge also to various people. Every day morning, I get up with his good motivational message. It's really good. I requested him to publish that also, because very few people are there to spread that message. So I'm very happy that Sadan Sethi has joined us. He's the one who is interested in hypertension specialists and hypertension clinic. And of course, Prabhakar is a preventive interventional cardiologist, Ashwin Clinic, Apollo Group of Hospitals, Mehta's Hospital, coronary interventions, lipidology, preventive cardiology, heart failure. He's a co-author of the Lipid Association of India Expert Council document Part 1, Part 2, and JOPI March 2016, clinical lipidology. The current research in coupleless BP with CSIR and CWERE and pulse measurement with a camera, ABBM, ApoB versus LDLC. Primary investigator in heart failure registry of Tamil Nadu. Author for 39 to 40 chapters in cardiology, Apollo textbook of medicine. And Sadan Sethi is the fellow of the American College of Cardiology, fellow of the European Society of Cardiology, member European Association of PCI, emeritus professor, Dr. D.Y. Patil University School of Medicine, and head Department of Cardiology, Somya Supra Specialty Institute, Sion, Standard Healthy Living Center, Sion, Mumbai, founder Sadan G252 Foundation, founder CVD India, editor-in-chief for India Cleveland Hall of Fame, biography and patient education ebook. More than that, he's the most sought after speaker, and every day he has some webinar or other. So whenever we invite him, he readily joins, just because we'll share the knowledge in the common platform. And next webinar of this series is 1st July. This is going to be, I am the speaker, Dr. Prabhakar, Pradeep Kar will be the epidemiologist panelist, and Sangram Bradar will be a moderator. Now, last week we were talking about the burden in India, hypertension. This was very important because people don't realize that India's population is 1.3 billion. The estimated number of hypertension patients is more than 200 million. See, diabetes is only 65 million, whereas we have 200 million of hypertension patients. And the pre-hypertensive stage, which if you see, there are another 50 million. So blood pressure control rate is less than 10%. If you see, the prevalence is 28.5. Awareness among the prevalence is only 27.9. And the people who are on the treatment is 52.1 only. And then control is 44%. The people who are taking treatment, control is 44. Thanks to our Indian Hypertension Control Initiative, with the aggressive programs, the control rate has come to 44%. But in the overall, still it is less than 10%. And the hurdles is diagnosis was problem, treatment no protocol, drug shortage, therapeutic inertia mainly, private sector treatment is different, patient flow is different, continuity of care, no reminders, no recall system, no follow-up, no information system, low adherence. So these are the hurdles for poor control of hypertension. And of course, last time we talked about accurate blood pressure measurement. And then many people have this tool in the clinic, which I think they should remove, and they must follow the proper method as what we described last time. The opportunity screening is a very important point, which I think everyone who is listening should understand. Whenever somebody comes to you for any problem, even for little finger injury or abdominal pain or fever, you will have to check the blood pressure. Anybody aged about 18 years, you should be screened for high blood pressure. And also the patient attendants who come, they should be checked. And whenever they are waiting in the lobby for doctors, there also, the paramedicals should check the blood pressure. And if the blood pressure is high, they should be referred to the doctor. And data from the longitudinal aging study in India, that's called LASI, among 45 plus age group, showed among those identified as having hypertension, only 22.6% had not been diagnosed despite having recently visited a health relative. So they have come to the hospital. In spite of that, they were not identified as hypertensive. So that's a poor thing. That's why opportunity screening is very important. Missed opportunity for diagnosis were more common at private than at public health facility. So ladies and gentlemen who are watching this, please utilize the opportunity and do the screening. And of course, the monitors are mercury monitor, aneroid, and digital. And of course, now mercury is slowly going up. And aneroid, of course, mechanical shocks may lead to incorrect reading, needs calibration every 6 months. And the digital is now everywhere, highly reliable when validated instrument is used correctly. So it should be a validated digital monitor, and then observer skill and expertise is low. And also observer bias is simple, no. Use by field workers is very simple. Availability in the near future is yes. So more and more digital monitors are coming. Again, the digital BP monitors, fully automatic, cuff inflates automatically and estimates systolic and diastolic BP. There are two different types of BP monitors. One is semi-automatic and other is fully automatic. And fully automatic and semi-automatic devices do not require calibration. And these are the instruments. This is mercury, this manual, semi-automated, automated devices, and emerging technology. Because many people last time asked me in the chat box, what are the types of BP monitors? So choosing a digital monitor, you should always look for validation. Validation is a documented process that provides assurance that the product consistently provides results within the acceptable criteria performed as per the standard validation protocol. Calibration is a process that ensures that accuracy is maintained in the measurements produced by the equipment. This is typically done by testing the device against gold standard to identify any drift in measurements and eliminate it. So the validated monitors are available in the market. Patient's blood pressure within certain level of accuracy. Most marketed devices are not validated. Three main validation protocols: US Association for the Advancement of the Medical Instrumentation, International Standards Organization, British Hypertension Society, European Society of Hypertension. Validation to be conducted by an entity not affiliated with the manufacturer. List of validated devices available on the website of Hypertension Canada, British, and Irish Hypertension Society. We have requested ICMR also to come forward to validate the BP monitors available in India. And non-validated BP devices dominate the online market. A study from Australia how the readings are bad. So we have to have a validated BP monitor. Professional digital BP monitors for clinical use. We have got models which I think it is available in our website. Armin BP monitors suitable for high volume facilities, just like weighing machine in the market. You should have something like this so everybody can go and check their pressure. So this is going to come in many public places. And then while procuring monitors, see only professional BP monitor, automatic preferable, semi-automatic can be considered for sub-centers. Evidence for validation should be available. Accuracy information should be available. Warranty at least 2 years. Availability of service centers, BP monitors that store fast readings, monitors that link to iOS or Android, portability, personal use. These are the points before you purchase the monitor. Now, after Prabhakar, we are going to have a Kahoot as usual. And those of you who have joined recently in our forum, please download the Kahoot app in your laptop or mobile and be ready. We will give you a game pin number. Please enter the pin and your name. Then you can play. There are 10 questions today. For each question, 20 seconds we give. You have to answer. Those give correct answers early will get more marks. With this, I now request Dr. Prabhakar to take over. I also have taken time just to make sure everybody gets it so that when Prabhakar comes, the hall is full. Now I'll stop sharing. I'll request Dr. Prabhakar to present his presentation. Over to you, Prabhakar. And I am also very happy to welcome Dr. Bhubadi John, who is our observer. You know, we are giving the Medical Council accreditation. Every time when we do Medical Council accreditation, the Medical Council sends observer to see whether we are doing the program, how many people are there and all that. So this is how we get the real credit. And my good friend Bhubadi John has joined us. So welcome, Bhubadi John. Please enjoy the feast by Prabhakar and Sadanand Shetty. Over to you, Prabhakar, please.
Thank you so much, sir. It's always a pleasure sharing a stage or a screen with you. And when you give a topic, it's always a little challenging, and I learn a lot. When I give a talk, I learn a lot. So that I think is the biggest advantage of a speaker. So first, let me thank Dr. Muruganathan and Dr. Sadanand Shetty, who's, I can just tell you simple words, he's a great man in several terms. So I think it's nice to have him as a moderator today. And Dr. Sangram Birdar, I met during the Epicon also, Lycon, and welcome, sir. So without wasting much time, let me go into my talk. I shall be occupying you over the next about, let's say about 30 to 40 minutes on just one aspect. I'm just going to focus on the systemic hypertension in adults, the WHO statement, which came in 2021. Now, it's a very interesting statement, and the point that I really want to tell you first is very important, which is that this guideline or this guidance is basically meant for chronic management of hypertension in primary care. It's not an advanced statement. It's a chronic hypertension management in primary care, and it overrides the previous modules. So it replaces the HEARTS technical package and the WHO PEN package, which were in vogue before. So this is a new document, and this is what is going to be followed. The prevalence of hypertension, Dr. Muruganathan sir had already said it. 14 seems to be the lucky number for hypertension. 1.4 billion people, are having hypertension worldwide, but of which only 14% have the blood pressure under control. We are looking at global statistics. When this is so bad and so abysmally low, I think the WHO is very correct in trying to simplify management at the primary care level, because not everybody comes to a consultant, not everybody comes to a specialist. So how do they formulate? They had a very, very nice protocol. They had a framework on treatment of hypertension. They asked several questions and gave answers to it with scientific evidence. And the first question they asked was, at what level should pharmacological therapy be initiated? Are lab tests required? Do you have to risk assess these patients? Monotherapy, no therapy, monotherapy, combination therapy, which is the best? Single pill or a free combination? Post-treatment, once you start treatment, so far you're looking at treatment, what is going to be a target for blood pressure? And ultimately, when do you reassess a patient? And should a physician only be involved, or a pharmacist or a pharmacologist can be involved in this treatment? So basically, when they look at it, they've looked at two results: the intermediate outcomes and the final outcomes, which is we call the hard endpoints: all-cause mortality, cardiovascular mortality, myocardial infarction, coronary artery disease, stroke, and heart failure. In between, there is also a small component of adverse effects, which is also taken into consideration in these group of patients. Now, before they went into the data, there's not much of discussion, but they have clearly made a mention that non-pharmacological approach is very important and part and parcel of hypertension, which we very often neglect. Now, remember all these points, each one of them contributes to reduction of blood pressure. Reduction in salt intake, just avoid excess salt, bring down to about 5 grams. Eat plenty of fruits and vegetables. Be physically active, about 40 minutes most days of the week. avoid tobacco, reduce alcohol consumption, and limiting intake of foods rich in saturated fats, eliminating trans fats. Very simple. You can tell this to your patient in about half a minute. It took half a minute for me to read the slide. So I think if you're just going to give these principles of diet, it is going to be fairly important for the patient. This will bring down the blood pressure by about 5 to 10 millimeters consistently, and that's going to be very, very important. Now we'll go through the questionnaire and see how this document was framed. At what blood pressure level should pharmacological therapy be initiated? Now, why does this assume important? Because there is a big diff between the American and the European guidelines. Across the Atlantic, the Americans say 130/80 is diagnosed of hypertension, while the Europeans still stick to 140/90. The WHO did its own analysis, did beautifully, and looked at the baseline systolic blood pressure, drug treatment versus no treatment. What is the amount of relative risk reduction? Now, first, let us look at all-cause mortality. Now, the dark blue bar, which is here, is the blood pressure, which is 140 to 149 at initiation, more than 140. The orange one is 120 to 140, and the light blue one is 120 to 130. The green is 130 to 140. Consistently, if the blood pressure is more than 140, there is benefit in all-cause mortality, cardiovascular mortality, myocardial infarction, not much of data, but still there is going to be reduction in the stroke and heart failure also. What we are interested in is 120 to 130 and 130 to 140. Look at the difference in mortality, all-cause mortality, -2 and -3%. Look at the difference in the cardiovascular mortality, -2 and -1%. There is a reduction in stroke when you reduce the blood pressure, but overall, it doesn't seem to be reducing the mortality. There is a reduction in stroke and heart failure, but the benefit is not very, very clear. Now, what happens if your systolic blood pressure on treatment or not treatment, if the patient is having coronary artery disease and diabetes? Now, we are looked in here at all hypertensive patients. Now, when you look at a subset of coronary artery disease and diabetes mellitus patients, you see that patients with a blood pressure of 130 to 140 and more than 140, you compare these two, there is a remarkable improvement in patients who have a blood pressure of 130 to 140. With coronary artery disease, without coronary artery disease, and with coronary artery disease, there is an improvement. Again, if you look at diabetes, if the blood pressure is less than 130, there is a nearly 13% improvement. Now, this amounts for all-cause mortality, cardiovascular mortality, myocardial infarction, stroke, everything shows improvement. Clearly showing that all hypertensives are not the same. The cardiovascular disease patients and the diabetics and the high-risk patients are going to be different. High risk will come to a little later. So what is going to be the definition of hypertension in these group of patients? Clearly, WHO recommends a 140/90 as the blood pressure for all persons. Now, if you have an underlying heart disease, we already saw in the previous data that 130 to 139, your patient is going to benefit from treatment. Now, the patients with high cardiovascular disease, diabetes, and chronic kidney disease also benefit. So your definition of hypertension is 140/90 for everybody. If you have coronary artery disease, high risk for cardiovascular disease, diabetes, and chronic kidney disease, you are going to benefit from 130 systolic blood pressure treatment, 130 to 140. Now, this is important for your definition and practically treating treatment, but definitely 140/90 is the important thing. Now, having made a diagnosis, how long can you wait before you start treatment? You don't wait more than 4 weeks. The maximum time permitted is 4 weeks. But should you wait for 4 weeks for all the patients? No. If your blood pressure is more than 160/100, or if you have an end organ damage, like let's say a left ventricular hypertrophy by the echocardiography, you don't have to wait even the 4 weeks. Straight away, you can start treatment. Initiation of treatment without delay is mandatory in these group of patients. Now, you must also understand that they did a specific model called the Kostova model study for low and middle income countries, and they found out that the best by cost-effective treatment was when you start treating patients more than 140/90. The SPRINT trial contested this. They also went ahead and analyzed this data, and even the SPRINT trial's cost-effective analysis showed it is not a cost-saving analysis, and you have to maintain this low blood pressure consistently for more than 5 years to show these beneficial effects, which is not really easily possible. 5 years consistently low blood pressure is not going to be that easy. So having looked at this, once you've made a diagnosis of hypertension, what are the tests that you're going to order? We don't start medication straight away for hypertension. So what do? You generally ask for some laboratory tests. What lab tests are you going to ask for in these group of patients? Should you do it at all? Now, when you want to do these patients, the first thing you must understand, your lab tests should not delay treatment. That is very important. And what are the tests recommended? Very simple tests. One set of investigations like serum creatinine, electrolytes, and a urine examination for the kidney function, a lipid panel, either a blood glucose or HbA1c and a simple electrocardiogram. So these tests are useful. Now, is it always useful? It is beneficial clearly in certain specific conditions, which I'll come to in the next slide. But there are some caveats and problems also. Sometimes you end up with incidental findings, and that might delay in starting in treatment. And don't wait for these results, especially if your blood pressure is more than 160/100 or you find left ventricular hypertrophy. So be careful. Don't let it delay your treatment is very, very important. Now, the condition specifically where this is important and useful is diagnosing secondary hypertension. Though the prevalence is only about 5 to 10% of all hypertensives, if you look at patients who have multiple risk factors or comorbidities, the prevalence goes up from 23, 24, and 39%. Suppose your patient is having multiple risk factors like diabetes, dyslipidemia, smoking, and other factors, the incidence of secondary hypertension is actually on the higher side. So you have to be careful. And it also helps you to guide what is going to be your kind of treatment. Like suppose if you're a diabetic, you're going to benefit from RAS inhibition. If you have hyponatremia, your basic electrolytes show that the sodium is low, you're not going to use diuretics. If your potassium is low, you are looking at probably a secondary hypertension. Second thing is these patients are definitely going to benefit from RAS inhibition and probably the MRAs or the spironolactone as we look at. So lab results definitely have a clear benefit. And you also look at hyperkalemia. If you have hyperkalemia, you're not going to give the RAS inhibition. You're going to be looking at specific causes. So laboratory investigations are beneficial. So the recommendation is you can do those set of investigations for the kidney, the sugar, the lipids, and the ECG. And if you're looking at this, definitely treatment should not be delayed. And if you don't have these investigations, now mind you, this document is meant for primary care physician. Now, if there is a physician sitting in a village without a lab, he doesn't have to wait. Which is the safest drug to start? The safest is a long-acting calcium channel blocker, dihydropyridine calcium channel blocker like amlodipine. So this is going to be the drug of choice in a primary care setting when you don't have investigations. What I call as the general practitioner's treatment of choice is going to be a calcium channel blocker. Now, once you have done this, the common parlance nowadays is to look at risk assessment. What is the risk of developing a cardiovascular disease? We keep asking that again and again. Now, should you do this for everybody? It's very, very simple. Once you have diagnosed 140/90, you fall into the high risk category. No further risk stratification is going to be absolutely essential. But if you're in the 130 to 139, you calculate the risk score. The risk scoring system, the best one for India seems to be the JBS3. If you fall into the high risk category, then a 130/139. Having said that, you must also realize that those patients with CKD, those with diabetes already come into the 130/139 bracket for treatment. So the risk stratification has some benefits, especially in those patients where you think they will benefit from these kind of treatments. So far we have seen that 140/90 is the blood pressure for treatment, 130 to 139 for certain specific group like heart disease. Do not delay treatment for the lab investigations. The risk stratification needed at some point, especially if it's going to be 130/90. Next, we are going to look at, once you've made the diagnosis, how do you treat these patients? Monotherapy or lifestyle modification? Or within monotherapy, which is going to be the best monotherapy to do? When you look at these, we are spoiled for choice. When it comes to drugs, we have a whole lot of these drugs available. The ACE inhibitors, ARBs, diuretics, beta blockers, calcium, alpha blockers, beta blockers, MRAs, the clonidine, moxonidine. Nowadays, minoxidil, alpha-methyldopa is not in the market. So all these drugs are available. So how do you choose these drugs? I keep telling this very simple. Basically, you go to a doctor, any doctor keeps juggling with drugs. Each doctor has got his own choice of juggling. He judges different drugs differently. And patients keep jumping from one doctor to another when they realize that the BP is not getting controlled. But mind you, it can sometimes be dangerous playing with fire because of side effects also. Ultimately, hypertension treatment, what I believe in clinical practice is something like this. Everything keeps happening fine. Nothing happens till there is a complication or somebody drops the baton, but it just keeps going on. Now let's come back to subject and look at what we are looking at. Now, basic class of drugs are going to be the thiazide diuretics, the low dose or the high dose thiazides, the ACE inhibitors, the calcium channel blockers, beta blockers, and the ARBs. Now look at 2 points here, the mortality reduction or the MACE reduction. The green one is the ACE inhibitors. They score over all other therapies, both in terms of mortality reduction and MACE reduction. When it comes to mortality reduction, the next spec seems to be the ARB. So basically the RAS inhibitors seem to be the best drugs. What are the closely competing drugs? The thiazides seem to be fairly pretty well. The green ones are the calcium channel blockers. They are good. Look at beta blockers. They don't have much of a benefit in terms of mortality reduction, and there's not much of benefit in terms of MACE reduction also in hypertension without any comorbidities. So mind you, this is the reason why we keep saying the RAS inhibitors are very important in treatment of hypertension. Now, the WHO came up with a simple protocol for management in clinical practice. Now, this is just an example. Don't take it as Godspell, because this is not the ultimate treatment. You can replace the drugs. Now, the basic concept of treatment in this group is a simple algorithm. Start with a simple drug like amlodipine 5 milligram. 4 weeks, you can wait. If it doesn't, step it up to amlodipine 10 milligram. If it doesn't, another 4 weeks, add telmisartan 40. If it doesn't, make telmisartan 80 in addition to the 10 milligram of amlodipine. If it doesn't, 12.5 milligrams of hydrochlorothiazide or chlorthalidone, then double it. WHO clearly says at this point, the patient should go out of the primary care. So that is the simple algorithm they've set. Now, why do they keep talking about the calcium channel blockers? Now, look at this data. This is analysis from the WHO annex. They gave a separate appendix and gave a beautiful analysis on Asian patients taking calcium channel blockers versus non-calcium channel blockers. Look at the hazard ratio for cardiovascular mortality, 1.1, MACE events 1.02, clearly showing that calcium channel blockers versus all other antihypertensives, calcium channel blockers are very good, and you can start using them as first-line therapy in most of these patients. So recommendation on the first-line therapy, clearly, it's going to be calcium channel blockers if you don't have investigation, but otherwise, look at the results. ACE inhibitor and the ARB seem to be better. You can start the diuretic. So it can be any one of these three agents that is going to be beneficial. But you must also remember there are some certain specific indications, like what we call as horses for courses indications. Like if you have an elderly gentleman who's more than 65, or somebody who's an African-American descent, their diuretics and calcium channel blockers are superior. We'll not go into the data for this. Beta blockers in ischemic heart disease. Now, is it only ischemic heart disease? Because in India, beta blockers are extensively used. I give a good name for that. I call it the happy indication for beta blockers. What is happy indication? Beta blockers are specifically indicators in heart failure, atrial fibrillation, angina pectoris, post-myocardial infarction, and a young woman planning pregnancy. So happy indication is somewhere beta blockers are going to be beneficial. ACE inhibitors and ARBs are going to be the important drugs for patients with proteinuria, diabetes, heart failure, and kidney disease. So we have clear indications apart from the general hypertension. Clear specific indications also have to be borne in mind when you start treating these group of patients. So far we have seen all these monotherapies, but what about these combination therapies? Because nowadays we keep talking about 2 drugs, single pill combination, 3 drug, single pill combination, all those things. Now, what are all these things? Now, basically, you must also understand there are 3 types in which you can increase the antihypertensive therapy. What we saw was the step care approach, where you start one drug, go to the maximum drug dose, and then step it up with the next drug. Now, this is this conventional step care approach. There is also something called the sequential monotherapy. You start one drug like telmisartan 40, add the next drug, then add the third drug. This is called sequential monotherapy. Then there is a new concept, which is the low dose combination therapy, wherein probably use a 6.25 milligram of chlorthalidone, telmisartan, or a 5 milligram amlodipine with telmisartan 40 milligram. I'm just using prototype drugs. It can be any other drug also. So there are 3 kinds of therapies, and which of the 3 is better? Is there any head-to-head trial? Is there a data? Yes, there is a data. There is something called a Strate analysis, where they just did about 200 patients each of these group of patients, and they found out that the patients who achieved target blood pressure was best if you initiate therapy with a low dose combination. Next best is sequential monotherapy, and finally the step care approach. So what we should be probably looking at a low dose combination therapy. You must also look at literature and realize that most individuals are going to require more than 2 drugs for the control of blood pressure. And when you combine 2 drugs, the efficacy is much better than individual drugs, and the adherence and persistence are definitely much better. The WHO also makes a very, very interesting statement, which I think all of you should understand. This is the amount of BP reduction is more important than the choice of antihypertensive therapy. There is an importance difference between the choice, but ultimately what is most important is that the amount of blood pressure reduction is absolutely essential. So when you use a combination therapy, non-adherence rate is highest when you use 3 drugs, 40%. But if you use a single drug, single pill, the non-adherence rate is just 10%. Now this works for all chronic therapies. And when you use a single drug like a thiazide or a beta blocker, ACE inhibitor, or a calcium antagonist, the blue is the amount of BP reduction, systolic BP reduction given alone. But if you combine with other drugs, nearly doubling of the effect happens in most of these drugs, clearly showing that the benefits are going to be enormous. And whenever the blood pressure is more than 20 by 10 millimeters of mercury, it is beneficial to start a combination therapy. So combination single pill therapy we have seen has 2 significant benefits. One is the blood pressure reduction is much superior. Side effects are much less because they can countermand each other. Like for instance, if you combine an ARB and a calcium channel blocker, the edema seems to be coming down. So and if you combine it, the diuretic with that, the amount of hypokalemia also comes down. So all these combinations have their own benefits. We'll not go into that. There's several data to show that the single pill versus no single pill combination, basically giving the drug separately, the combination pill is much superior because compliance rates have been much better. So we have seen three major therapies: the thiazide diuretics, ACE inhibitors and ARBs, and long-acting calcium channel blockers. Now, which is going to be a drug of choice? Which is going to be the choice of the combination therapy? There is some data to that effect, and the WHO has analyzed the data and shown that the two major combinations are going to be RAS inhibitors, calcium channel blockers, and a RAS inhibitor plus diuretic, of which the major contribution came from the ACCOMPLISH trial. And when you combine these two, look at the cardiovascular event rate, 18 fewer for 1,000 patients. Clearly, the combination of the RAS inhibitor and calcium channel blocker was superior to the combination of the diuretic in terms of mortality, cardiovascular events, stroke, and even withdrawal due to adverse effects. So clearly showing that the first best combination is going to be a combination of a calcium channel blocker and an ARB or an ACE inhibitor. So the WHO came up with a second algorithm for a combination therapy and said that the first drug, if you want to use, start a low dose combination like a telmisartan 40 and an amlodipine 5 milligram. Next, you can double it to 80 milligram telmisartan plus 10 milligrams of amlodipine. If it doesn't work, add a chlorothalidone or hydrochlorothiazide 12.5 and then double it up. Now, at this point, WHO clearly says that if you're in a primary care, beyond these drugs, don't push your patients. I'm quoting WHO, but I'll talk about this a little bit later. So WHO said, finally, that those patients with more than 20/10 definitely start a combination therapy. Otherwise, it is generally preferable to use a single pill combination with at least two drugs. The compliance is better, adherence is better, the effective blood pressure lowering is fantastic. Both adherence and persistence is going to be better. So what is going to be the target blood pressure? We have started therapy at 140/90 or 130/80. So how low should you bring out blood pressure? Now, if you look at the SPRINT trial, that is the trial that questioned everything and said that bring down the blood pressure quite low. Now, you look at the blood pressure between 120 versus 130 to 139. The all-cause mortality came down by 27%. Cardiovascular mortality came down by 40%. But go down and see what happens here. There is a 20% increase in, not 20%, sorry, 20% increase in persons who are getting adverse events. So the trade-off is that you have more adverse events if you try to aggressively treat these patients. Similarly, if you look at 140/90 to 150/160, 140/90, the benefit seems to be more, adverse effects seem to be much less. So clearly, if you try to go too low in the wrong patients, you will land up with more adverse effects. So what are we looking at? We are looking at splint-like results in patients who are going to be sprint-like. So what is the inclusion criteria for sprint? Patients age more than 50 with a systolic blood pressure between 130 and 180, increased risk of cardiovascular disease. Either there should be a cardiovascular disease, chronic kidney disease, Framingham score more than 15, or an age more than 75. Now look at all these factors. We have already gone ahead and said that 130 seems to be the good blood pressure to start treatment in most of these patients, like multiple cardiovascular risk factors like diabetes, chronic kidney disease, or high-risk patients. So it more or less corresponds to that. And if you start treating these patients, what is going to be the cost? In US, it seems to be $13,000 more costly. It's quite high. Patients require more visits, more medication. It is much more expensive. And treating to lower targets will reduce the returns progressively in low-risk patients. So don't try to be very aggressive in low-risk patients. It may not really benefit. So what is the recommendation by WHO for the target blood pressure? 140/90 for all patients. Again, if you look at it, it comes similar to where we initiate blood pressure. Those with cardiovascular disease less than 130 systolic, those with diabetes, high-risk CVD, and chronic kidney disease less than 130. So it is more or less where we start. That is going to be the target blood pressure, which seems to be having the most cost-effective treatment. Now we are always wondering how low can we go. There is a recent paper in 2021 which looked at patients who had achieved a systolic blood pressure of 130, and what about the diastolic blood pressure, which is going to be the sweet spot. If your blood pressure goes less than 60, there is a clear U-shaped or a J-curve in terms of primary outcomes, all-cause mortality, non-fatal stroke, non-fatty myocardial infarction, MACE events, cardiovascular death. So your sweet spot, if your systolic blood pressure comes to 130, don't bring your diastolic blood pressure less than 60. That seems to be very, very important in these group of patients. And once you've treated these patients, how often should you follow up these patients? Now, if you start a drug or if you change the drug, you have to recheck the patient 1 month later. And once you've treated these patients 1 month later, you must also get to the control. Once you have achieved control, ask them to come back every 3 to 6 months. If not, they are just non-compliant. They just forget the drug. It's very, very important. I forgot one important point here. Let me come back here. Now, if you start treating these patients with ACE inhibitors or ARB, you must monitor the renal parameters and potassium, which is there in the side grips. I forgot just before you leave out of this. Remember, you have to be monitoring at least once after 1 week once you start these therapies for these patients. So we have seen the J curve happening. We've seen the follow-up of these patients. Now, what happens if you delay treatment? Delaying treatment or intensification of treatment clearly leads to increased cardiovascular death and mortality. Who does this? The doctor inertia. The doctors should learn to treat these patients. Now, if you start BP treatment, if you delay treatment by more than 1.4 months, 1.4, about 1.5 months, if you don't initiate treatment, the MACE event rate is 1.12, 12% increase in MACE rates. Suppose your blood pressure is on treatment and you don't follow them up for at least a period of close to 3 months, about 2.7 months, your MACE event rate goes up by 18%. So clearly, it is not only treatment of hypertension, your initiation of treatment and follow-up also leads to problem. Now, if your patient doesn't get control, now I'll go off the WHO guidelines for those people who are sitting and who want to learn how to treat beyond the 3 drugs. This is basically from the NICE guideline, which is also endorsed in 2020. Once you have taken all 3 drugs, the RAS inhibition, the calcium channel blocker, and the diuretic, the next step is to look at serum potassium. Look at serum potassium less than 4.5, more than 4.5. If your potassium is less than 4.5, you add an MRA like spironolactone, repinerone. If your potassium is more than 4.5, don't give these drugs because the incidence of hyperkalemia is higher. If it's more than 4.5, look at the heart rate. If your heart rate is more than 70, give a beta blocker. Less than 70, alpha blocker. By this time, most of your hypertensions are controlled. So we're looking at nearly 5 drugs here, and you should have a reasonable control with this group of patients. Now, recommendation for non-physician professionals, there is a big case for pharmacists treating these group of patients. I don't know how applicable it is to India, but there is also a reasonable result, and the results are pretty good if the pharmacists treat. In fact, the barber study, if you remember, the pharmacists in the barber shop among Black community had a much better results than the hospitals. So there is a real entity there, but you have to train them, give a clear protocol, and know how to treat these patients. So basically, coming back to the first slide that I put in, 1.4 billion people have hypertension, but the control is 14%. And why? Why is there so much of problem? Basically, because of clinical inertia. The 3 inertias: the physician factors, the patient factors, and office factors, several factors. Physician not knowing what he has to treat, he doesn't initiate treatment, doesn't titrate, doesn't identify, doesn't follow up the patient. Patients are not bothered because they're not having enough education to understand their cost of the medication can be a factor, and those patients are not really worried because it doesn't really produce symptoms. It can be a silent killer. The other factors, there are no clinical guidelines that are accepted by national societies. There are a lot of guidelines, but nobody seems to be bothered. And there is data to show that if your initial inertia is not there, 10-year outcome, most of your patients get a good BP control. If there is inertia, most of the patients do not get controlled over 10 years. So if you remove the initial inertia in 1 year, even 1 year, the amount of patients getting control is good. Like if you wait for more than 2 years, the amount of blood patients getting controlled is not so good. There's another very interesting paper, Gillen et al., which showed that there are 2 kinds of inertia. That is going to be what is called as a diagnostic inertia and a therapeutic inertia. It's interesting. Diagnostic inertia is your sister checks the blood pressure, and if the blood pressure is 146/90, she chooses to write 140/90 because it looks like good control. This is diagnostic inertia, which is man-made error. And therapeutic inertia, where the doctor doesn't treat the patient. Now, remind you, diagnostic inertia is seen nearly 32%, and therapeutic inertia is seen in 37%. Is totally avoidable, and your patient is the sufferer, and you have to look at this. Now, there is a mention about pregnancy and hypertension in the WHO guideline. I will just rush through this and just give you an idea. We are not going to discuss much about this. Basically, 10% of maternal deaths are attributable to hypertension. And chronic hypertension in pregnancy, if you are having a diagnosis less than 20 weeks of gestation, and the prevalence is 1.7%. Gestational hypertension is if you have it diagnosed after 20 weeks, and prevalence is 1.2%. The diagnosis is based on 2 blood pressure recordings more than 140/90, at least 6 hours apart. It doesn't have to be on several occasions. 6 hours apart is more than sufficient. And interestingly, the threshold to initiate pharmacological treatment is very high at 160/105. to diagnose, but the initiation of treatment is pretty low. Now, recently, there is a lot of data to say that you can bring down the blood pressure lower to 85 millimeters of mercury, because formerly we said don't bring it down less than 100. This seems to be having some beneficial effects in maternal and fetal risk, which is a very important document, which is also presented in the ACC-AHA recent conference that was held in March 2022. Target organ damage, if it is present, start treating much earlier and don't wait for treatment. Drug treatment, I'm sure all of you are aware of this. The drug that is going to be first is going to be methyl dopa, beta blockers, preferably labetalol, calcium channel blockers, particularly nifedipine. You can use the hydralazine, the direct acting vasodilator. Beta blockers and calcium channel blockers appear to be more effective than methyl dopa actually in reducing later pregnancy. That is important. Thiazide diuretics, you can't initiate them, but the patient is already on that, probably you can leave it. The red flag drugs are the RAS inhibitors, MRA antagonist, spironolactone. They can be some fetal anti-androgen effects, so be a little careful with the MRAs. And beta blocker atenolol has been shown to produce intrauterine fetal growth inhibition. So be a little cautious about these drugs and don't start using these drugs. So finally, to summarize whatever I have said, the blood pressure threshold for initiation of treatment is going to be 140/90. 130 systolic is going to be the blood pressure for patients with cardiovascular disease, high risk for cardiovascular events, diabetes, and chronic kidney disease. Laboratory testings, if possible, but don't delay treatment because of laboratory tests. And if you don't have the test, the drug of choice is going to be a calcium channel blocker. Cardiovascular risk assessment may not be required immediately, but if those patients between 130 and 140 who don't qualify for drug therapy, it may be prudent to look at high risk factors and start treatment. Drug classes to be used as first agent, all three drugs, the RAS inhibitors, the diuretics, and the calcium channel blockers, any of these can be used. And if you look at the best drug, that seems to be the RAS inhibitors. And the combination therapy, the best combination seems to be a RAS inhibitor with the calcium channel blocker. That seems to be the best possible combination at this point of time. Antihypertensive therapy with target blood pressure is more or less similar to our initial blood pressure, 140/90 for everybody. For the high risk group that we had already mentioned is going to be 130 systolic. Frequency of reassessment every month till you control, thereafter once in 3 to 6 months. I think with this, I should say thank you to Dr. Muruganathan and all of you for the patient listening. And I will say thank you and come out. Thank you, sir.
Yeah, thank you, Prabhakar, for that excellent, very simple, lucid presentation. I think all our viewers were very happy about your simple presentation. There are a lot of questions in the chat box. Now I'll go to the Kahoot, and then after Kahoot, we will ask Dr. Sadanand for his expert comments, and then few questions he can answer. Now, please get ready for the Kahoot. Those of you who joined, please download the app. The game pin number is 835-2772. Game pin number is 835-2772. Huh? No, waiting for the play. Yes. Another 10 seconds. Those of you who joined new, just enter the game pin 835-2772, and then you will get you can play the game. All our good friends usually who are joining, they're there, but I want the new people also to join. I'll give you another 10 seconds more. Now this Kahoot has, by itself have formed 3 teams: Fire team, Ocean team, and Sunshine team. It was formed with the default, but anyway, it doesn't matter. We'll see Fire, Ocean, and Sunshine. So you can add one more team also. But this is the Kahoot's team
We should have actually named it as ACE inhibitors,
Yeah.
ARBs, and calcium channel blockers or something.
Actually, Prabhar, I myself don't know this because suddenly my secretary did something and it has come like this. First time I'm seeing these comment teams. Doesn't matter. Last 3 seconds. I told you in the beginning, those who play Kahoot in all the 5 will be rewarded with BP monitor. Okay, I'll stop with this now. Yeah, 2 more seconds. Kalai, why you are so late? You are always join early, but okay, let's start now. 3, 2, 1. The first question: isolated systolic hypertension is common in young, elderly, or pregnancy? Very simple question. You don't need to have 20 seconds. You can give in 3 seconds. Yeah, I'm happy. Only 48 have answered. I think I would have expected 100%. Doesn't matter. Now let's see who's number 1 and who's number 2. The Team Fire is 743, and then Team Ocean is 722, and Team Sunshine 596. Let's see which team wins. The next one, the second question: which of the following is known side effect of ACE inhibitor? Hyperkalemia, hyperglycemia, hypermagnesemia, hypercalcemia. The small confusion come here. This is not there. All AA is come. Wrong. Okay, depending on the color we can do, yes. Super. Hyperkalemia, 62 people have answered. Nice. Let's see which team now. The Team Fire followed by Team Ocean. Now the first line antihypertensive drug of choice in diabetic patient is diuretics, ACE inhibitor, ARB, beta blockers, or calcium channel blockers. Sorry for AA, it is depending on the color you can choose. Yeah, it's angiotensin converting enzyme on the ARB. Before, again, Team Fire is still leading. Now the next initiation of pharmacological hypertension treatment should start not later than 4 weeks following a diagnosis, not later than 6 weeks following diagnosis, not later than 3 months following diagnosis, no later than 2 months. Prabhakar was very specific and clear in mentioning. So I think again 100% should be right in this. Let us see. '61, not bad. Not later than 4 weeks following diagnosis of hypertension. And if the initial pressure itself is more than 160 or 100, you should not delay. And if they have HMOD, hypertensive mediated organ damage, you should not delay. You should start. You should not wait up to 4 weeks. That's the message. Now let's see for Team Fire, Ocean, and Sunshine. Still Team Fire is leading. Estimated proportion of people living with hypertension in India with controlled blood pressure: 5%, 14%, 10%, and 18%. It is less than 10%. So only 15 are correct. So that's what we are interested in, and we want to promote aggressive control. Let's see who's now. Now the Team Ocean has taken over the Team Fire. Now let's see the next question. Which BP monitor is considered as gold standard? Aneroid, digital, mercury, or all? Yeah, mercury is supposed to be the gold standard. Now, Team Fire has come back again. Now, the seventh question: challenges in hypertension management are therapeutic inertia, low patient awareness, aversion to treatment, irregular treatment because of no symptoms, poor lifestyle, all of the above. What are the challenges in hypertension management? Therapeutic inertia, low patient awareness, aversion to treatment, poor lifestyle. Yeah, by 10 seconds, 70 people have answered. That's good. I think last 100%, I think we should get correct. Super. All of the above, only 4 defaulters, 68 have said correct. So these are the challenges. Again, Team Fire leads, Team Ocean. In patients with diabetes mellitus, when should antihypertensive drug treatment to be initiated? When systolic blood pressure is more than 140, when systolic is more than 130, when systolic BP is more than 120, when systolic BP is more than 150. So when with the diabetes mellitus, antihypertensive drug treatment should be initiated. Super. When systolic BP is more than 130. I'm glad most of you have listened to Prabhar well, and Prabhar was very emphatic. Team Fire still leading. Now the next question, 9th question. Control hypertension frequency of follow-up should be 1 to 3 months, 3 to 6 months, 6 to 9 months, 9 to 12 months. Controlled hypertension frequency follow-up. See, all these questions we are asking because this is what you should practice in your day-to-day. So when you learn by question and answer, you will never forget. So control hypertension frequency of follow-up should be 3 to 6 months. Now Team Fire or Team Ocean has taken over. Now the last question. In the absence of investigation, which is the antihypertensive drug of choice? In a primary setup where there is no lab facility available, what drug you start? Is it thiazide or thiazide-like, calcium channel, angiotensin, or all of the above? Good. Calcium channel blocker is a good drug which doesn't require any lab investigation. So you can boldly start calcium channel blocker because that is a drug of choice. So now we'll see the podium. Who is number 3? Team Sunshine. Then the runner-up is Team Fire. What Fire has come down, and the winner is the Team Ocean. Very good. So thank you very much. I will now stop sharing the Kahoot, and I'll go to Pradhanand. Sir, good evening, Pradhanand, sir.
Yeah.
Now tell me.
Yeah. Thank you, Muruganathan, for giving this opportunity, and excellent talk by Dr. Prabhakar as usual. And the WHO has given us the maybe primary care setting very clear message, which is more or less the guideline what we follow, even the ESC or even for that matter ACC also. And a few important things which has been stressed even by the WHO, that general population more than 140/90 is the level to start the therapy and to maintain the therapy, unlike a patient who has high risk or established cardiovascular disease. Even more than 130 we have to initiate the therapy. And this is what that is where little controversy of ACC came when we said more than 130, they said as stage 1 hypertension, and more than 140 at the stage 2. And then we were at that time, maybe 3 years ago, thinking that this will be over diagnosis of hypertension. But actually it is very, very apt for our country, particularly Indians, because when we see patient in our real world practice, hypertension is one part of the comorbidity of the patient. when you do their lipid level or when you do their even the sugar level, many times they may have some comorbidity. That is one thing very common. Second thing, by the time they come to us, they already got the target organ, the effect. And but as Dr. Prabhakar said, hypertension is a silent disease, and therefore patient may not recognize that I have got hypertension. By the time they get complication, then they become symptomatic. So it is very important at the sort of community level to diagnose and to at what stage to initiate the therapy and what target we have to see. So essentially the message is very clear. The WHO, like I am of the opinion, a strong follower of ACC, unlike the ESC and the NICE guideline, the Canadian, because Indian patient, we do see young patient hypertensive. He also has a dyslipidemia. He may be overweight. His lifestyle, like tobacco, the smoking, etc., is there. So he is already in the high risk. We don't do subclinical atherosclerosis study, etc. We may do the baseline checkup, but we don't do anything, to see whether they got atherosclerosis already set in. So we have to be very aggressive in particularly young people, Indian people, young people, because they have a cumulative effect of BP for a long time. Treating hypertension at the age of 25, 20, as against treating at 45, 50 is different. Because, by the age of, 40, 45, a patient who is already set in hypertension at the early age, already the cumulative effect of blood pressure has occurred. So that's a good thing. I would probably concur with the WHO. And that's an important message for all delegates, to the primary care, the family physician, that how we should initiate, when to diagnose hypertension, and what target we have to see. So it is not 140, 90 or 130, 80. It all depends on the risk of the patient. The risk of the patient is one, established cardiovascular disease or the high risk. According to me, Indian people are high risk. That's the way I look upon. Like, 1 in 3 people have got, dyslipidemia. Now, 1 in 4 people may have a pre-diabetic, and maybe people may have other, like, lifestyle, like, the tobacco smoking, maybe alcohol. And moreover, our salt intake is more actually. And we have, like, the salt sensitive hypertension. Our salt intake is more, and we are hyper salt responsive, unlike the Westerners. So we need to look into all these things. So that one thing is clear. Only one point of my difference between the single pill, like when you don't know anything, that's what my standard teaching used to be. When we don't know anything in hypertension management, start a CCB, that there is no contraindication, any obvious contraindication for CCB, and therefore a CCB, whether conventional one amlodipine or the now, the lot of new CCB like 4th generation, like we talk about, the cilnidipine, or we talk about the azithromycin, which has got the different type of, the ionic, this blockage, like amlodipine is conventionally the L type, and azithromycin is the T type along with the L type, and cilnidipine L and, the N type. So they have a, specific benefit, and we can start depending upon the cost factor, etc. Because amlodipine even is available in 1 rupee, 5 milligram, unlike, the azithromycin, which may cost about 10, 12 rupees, or cilnidipine, which also costs money. So therefore, in the community level, I would say CCB long-acting, still amlodipine, we can suggest. Only thing I may little differ in the combo, what WHO mentioned, amlodipine 5 to 10, telmisartan 40 to 80, hydrochlorothiazide 12.5 to 25, which is not my type of the thinking, because I am of the opinion where combination of something intermediate dose, like I don't exceed normally more than 5 milligram amlodipine, I don't exceed more than 40 milligram telmisartan, and by that time either hydrochlorothiazide or chlorthalidone. Fortunately, hydrochlorothiazide is again coming back. About 2-3 weeks ago, we had a seminar with Professor Mansia, and there is a big, the sort of a reverse going on. Unlike in the past, we used to say chlorthalidone and indapamide. Indapamide and chlorthalidone were the drugs of choice, but thiazide is also supposed to be, the drug which should not be disregarded. And maybe in our country, because a lot of preparation with hydrochlorothiazide, but possibly I may not exceed 12.5. So combo therapy of doubling amlodipine, then you are inviting the side effect. Telmisartan 40 to 80, you are inviting the trouble. Hydrochlorothiazide 12.5 to 25, inviting the trouble. give combo combination therapy, so therefore intermediate dose, so synergism, and using in maximum dose, side effect profile increases, like amlodipine at 10 milligram, definitely edema will be more than the 5 milligram. Telmisartan 40 versus 80 will have more hyperkalemia, maybe some patient with borderline CKD or creatinine, there may be an issue. Whether to use chlorothalidone or whether to use hydrochlorothiazide, till that webinar, I used to say always chlorothalidone indapamide, but now since hydrochlorothiazide is coming back, possibly there is a role to use hydrochlorothiazide also, but we have to be cautious of not using more than 12.5. And then, as Dr. Prabhakar rightly mentioned, that the MRA, that what ESC a few years ago said, till we use spironolactone MRA, we should not say hypertension is resistant. And therefore, either spironolactone or eplerenone, depending upon the cost factor, 12.5, 25 milligram, we can initiate at the fourth drug. Only thing is that beta blocker in our guideline, even the WHO, do not make much mention about it. But I personally feel in young hypertension in our people, and plus of course pregnancy hypertension, beta blocker is there. But in young hypertensive, probably the new generation like nebivolol, which is supposed to have, and that's what the Indian guideline on hypertension 2019 mentions, that nebivolol is a drug among the beta blocker. And I would see young people essentially because of hyperadrenergic, tachycardia, increased cardiac output, etc. So possibly I may use the drug CCB with beta blocker like nebivolol, or maybe even the ARB like Generally, ARB is our choice over ACE inhibitor, and telmisartan among the ACE inhibitor, ARB is a first drug we use generally, because olmesartan and the azilsartan, our frequency is less. Combination therapy, again, telmisartan and amlodipine will be the drug, will be preferred drug like that. So these are the few observations. Only thing in WHO, systolic, they mention up to about 130, and the diastolic cutoff 60, which is a little different than the ESC. ESC gave systolic don't go below 120 and diastolic don't go below 70. That is what possibly the one which is mentioned, WHO 60, but maybe a people who are having coronary artery disease, vascular disease, possibly you may keep diastolic pressure up to 65 plus 70. People who don't have coronary artery disease, maybe you can get down on the lower side, but that's what maybe that Prabhakar can clarify, that 60 versus the 70 ESC, whereas the systolic 120 versus 130. So this is one thing because of that U-shape phenomenon of the diastolic, particularly people who are suffering from vascular disease. People, if they're not suffering, then we need not, Though it's a diastolic pressure is a controversial thing. Some researchers say in elderly people, just measure systolic only. Don't measure diastolic, because if you talk to Michael Weber, he says, even if the diastolic come to 50, 60 at 75, 80 age, no problem, but get the systolic down. Point is, even at the age of 70, 75, 80, the systolic pressure brunt on the vascular system is more. So if it is possible, 130 patient can tolerate, 140, like what SPRINT trial has shown, even in elderly people, if they're desirable, don't worry about the diastolic. This is what many times you also may be having that comment, Dr. Muruganathan, about the diastolic pressure. This is always a little controversial issue. So all in all, I think most of the thing what WHO gave us, this revised at the primary level, is a simple and I would say which can be practiced. These are few of my comment about the Prabhakar's talk.
Yeah, I think before Prabhakar talks, because you asked me regarding the diastolic pressure, because during diastole only the coronary blood flow happens. So especially when a person with ischemic heart disease, you should not radically reduce diastolic pressure because that may produce problem. And as Prabhakar said, it may have a J-curve phenomenon. And as you said, systolic pressure is important in an elderly person, but still you are not supposed to reduce at least both the guidelines. One is 70, the other one WHO is 60.
Yeah.
So it's not prudent to reduce systolic. Coming back to your another question, which you said about the nebivolol. Recently, Sudan, I hope you would have seen the B3 agonist activity of nebivolol is is a repurposeful weapon. Already the weapon is there, now we are using, and nebivolol is used for lipolysis. It's supposed to reduce the adipose tissue in subcutaneous as well as visceral fat. So recent studies have said nebivolol is a good drug and that can reduce lipolysis as a B3 agonist. And not only there is a nitroxide NO donor, but some other effects like B3 agonist. Then you said about the amlodipine with nebivolol. I don't know whether you read that. There is a 5 articles have come. In Asians, the combination of calcium channel blocker and nebivolol is supposed to be far superior than other combinations.
Yeah.
Recent study. Then the third point which you mentioned about the the combination of amlodipine, telmisartan, the Indian Hypertensive Control Initiative has started in many states this protocol. We call them as simplified protocols as by WHO. What we do is we give amlodipine 5 milligram first, then second telmisartan 40, the third we add amlodipine 10, and then fourth we add telmisartan 80. So some states straight away start 5, 10 like that. But this is for convenience. These 3 drugs are available. These are the essential drugs according to WHO. All the government is supposed to store these drugs, 3 drugs, amlodipine, telmisartan, and chlorthalidone, and they do this for simple purpose. So this is what in many states we are doing Indian Control Hypertension Initiative. So that is the thing. Now we'll go to Prabhakar. Prabhakar, before you answer our Pradhan, you tell me what is stage 1 hypertension, stage 2 hypertension, stage 3 hypertension in WHO, and what is the treatment? Because I gave you a title to address those issues.
I saw your title, but the WHO, this particular guideline doesn't differentiate it like this. It doesn't qualify. This is a specific statement for primary care physicians. I actually think this is a better way of dealing with hypertension than calling it stage 1, stage 2, and trying to remember numbers.
Yeah, I totally agree with Prabhakar. In fact, that's why I like still ACC. Only 2 stages. 130 to 140, more than 140. Like that. Diastolic. Yeah, this also becomes. See, I don't know, because basically therapeutic point of view, you are going to see the control and you're going to adjust the pharmacotherapy. So it doesn't make a great thing, except for the level of BP starting. Like if you are to get down the BP more than 20 systolic and more than 10 diastolic, then you will initiate the combo therapy at upfront, something like that. That's probably only therapeutic angle I also feel. Otherwise, whether stage 1 or stage 2, we have to get the BP to the target level, isn't it, Prabhakar?
Exactly, sir. I think the message in this is very, very simple.
Only beta blocker, Prabhakar, in WHO, where they place beta blocker, Leopard pregnancy point. Otherwise, in our they're not mentioned anywhere. That's what I was little.
In fact, you're true, sir. In fact, the happy indication I introduced myself because that's actually from the European guidelines.
Yeah.
I wanted people to get the message that there are other indications because they only mentioned ischemic heart disease.
Yeah.
The other thing that like heart failure was not there, so I didn't want to give the wrong message. So I added that part myself. So that is something I added. A couple of clarifications on what you said. One about the stages of hypertension, sir. Yes. Practically looking at it, like what Dr. Sadanand said, like he summarized what I spoke for 30 minutes and 5 minutes and spoke to everybody. And one of the important things is that when you are looking at 140, 90 or 130 systolic as your initial starting target or your initial treatment or target, 20/10, straight away, don't hesitate. A single pill combination therapy is going to be the best. And therein a combination of low dose combination seems to be the most effective. And practically speaking, it works very, very effectively. I don't think it's a problem. I'll clarify that point about the J-curve that I've been talking. What I quoted is a specific trial wherein we are looking at a systolic BP less than 130 and the diastolic blood pressure. It's not the general J-curve like the other large scale studies. So that's what I said, 130 systolic. This is a very particular trial recently came up, and it's a meta-analysis of 2 or 3 major trials, which clearly showed that 60 seems to be a troublesome factor. So up to 70 we can leave. Now in this, we must also understand practically, all the automatic BP apparatus do not measure the diastolic blood pressure. They calculate the diastolic blood pressure. They look at the start of the Korotkov sounds, the peak blood pressure. From that, they use an algorithm and calculate the diastolic pressure. So the diastolic can be falsely low. So if you use a regular apparatus or go intra-arterially, you have a diastolic blood pressure, because there are times when you can use the Korotkov sounds in elderly people up to 0, even without aortic regurgitation. Yeah. So you have to be a little careful in your diastolic blood pressure there.
And the other thing, as you rightly mentioned, there is nothing like, we have any drug, particularly for the diastolic pressure, whatever we are giving for the systolic, it is also going to affect the diastolic.
Oh, that's
Though elderly people, isolated systolic or wide pulse pressure, CCB and diuretic are the drugs of choice like that, unlike the young hypertensive, which are normally high renin hypertensive. So low renin and the high renin. So maybe CCB either single or in combo with the diuretic may be a way to go in elderly people, because predominantly the decrease in systolic, unlike our other drug like ARBs and the other drugs like. So they are the drugs because of the low renin the hypertension is the cause. So that one thing. The other thing possibly, we have to, since a lot of primary care physician, little bit about the home BP, because that is also one of the important way of, keeping sort of, the target. Many times like white coat, we are sometimes underestimating or overestimating, like, initiating therapy when BP taken at home, there could be, a difference. And people can manage the pressure at home by seeing the blood pressure regularly at home BP, which becomes like a convenient for patient care and the dose adjustment. What do you say about that? Because that's what I think one of the important thing for, may not be for the WHO point of view, but in general,
Yeah, actually, the recent paper said they compared office BP, home BP, and ABBM.
Yeah.
They say the clinical outcome is better with home BP, and they say home BP is the best. That was a recent paper said. So I am the strong proponent of home BP monitor. I don't know what WHO says about home BP. Prabhakar, did you come across any?
They didn't mention much about all those. So they were just stressing about correct measurement of blood pressure, especially more so in the previous statement where the hearts that they are mentioning in, for the Americas. There they were stressing about how to measure blood pressure. Especially, I think the previous talk had mentioned that sit down with the back supported, feet flat on the ground, uncrossed, elbow rested on the table, wait for 5 minutes. And in fact, what is now recommended is 3 BP recordings. 5 minutes later, first one, 1 minute later, second one, and 1 minute later, third one. The average of the second and the third is what is the correct blood pressure. And home blood pressure monitoring, I teach my patients, we have a PDF file. We tell them exactly same: morning, wake up, empty your bladder, come sit down and do it before coffee, before walk.
Yeah.
And evening, probably a couple of hours before dinner, where the trough of the drug is going to be there for the night drugs. So those are the two right time, but additionally recordings can be taken.
Yeah.
Anytime you have symptoms.
Yeah. In fact, we have written a consensus statement a few years ago, where I was the first author about the home BP thing. The other thing, beauty of home BP, maybe we can also diagnose mask hypertension, which you can miss in the clinic, because sometimes what happens in the clinic, pressure may not be high, but we already see the target organ. See, we see LVH with a strain, or when you do the echo, you see there is a concentric hypertrophy, but pressure is not very high in the clinic. But when you measure at home, it's a different level. Like unlike our doctor-induced hypertension, there may be wife-induced hypertension or something, I don't know, or for wife, husband-induced hypertension, whatever you can call. So that reverse also can easily diagnosed by home BP. So I personally feel home BP is one thing we must probably encourage, not only in the initial diagnosis, but also for the maintaining, the therapy adherence. And one other thing, at least for the delegates, I just want to say how in my preventive clinic, I give importance for the hypertension. I always tell the patient that if you don't take medicine, you will get stroke, And that stroke is a very fearful sort of morbid condition for the people, general people, This is what I have been advocating right from my beginning of a career. At that time, a lot of preventive clinic and preventive talk, 35 years. But at least, becomes a lot of impact. I don't know what Dr. Muruganathan has got, how he tries to, put in the community that why you should take BP medicine,
Actually,
art is one thing, okay. But if you get BP, because again, people have silent disease, they don't have a symptom, the drug adherence to improve like this. And giving pill as minimum as possible. So I'm of the opinion, single pill, multiple drug, so that the drug adherence remains,
Actually, next week, we are going to talk about adherence only, and where I'm going to talk about single pill combination. Coming to your preventive cardiology, I always start with a beautiful slide by Christian Bernard. Christian Bernard, heart transplant surgeon, what he said, in my life, I have saved 150 patients by doing 150 transplants. If only I would have focused on preventive cardiology and checked the blood pressure, I would have saved 150 million people. This is the statement given by Christine Barnard. So my all talk will be, first slide will be Christine Barnard. I say we need not be Christine Barnard, we can be ordinary Sadanand, we can ordinary Prabhakar, where we treat hypertension, save more patients. So that way, what you say is preventive cardiology is much, much better, saving more patients than doing a transplant and save one patient with so many expenses.
I totally agree with you. That's what I was saying. Stage of heart failure is
Yeah.
just the control of risk factors. There's no structural disease. But
Yeah.
if you take care of blood pressure, take care of diabetes, obesity, weight, lifestyle, early stage, you can prevent large majority. I think, sir, here we have to do something, you
Yes.
being the hypertension, like
Yes.
a common thing at the early age to pick up,
Yes.
to prevent the cumulative effect, and how we can make an impact in the society.
That is why
Yeah.
in every webinar we are talking about opportunistic screening. So
Yeah.
even somebody comes and talks to you,
Yeah,
for some reason, you check the blood pressure for
yeah,
fun.
yeah,
And when you give home blood pressure monitor, all
yeah.
the children measure the blood pressure for fun and then bring the patient.
Correct,
And
correct.
then barber shop, which I did a program in one project, where barber shop also brings people, librarians bring patients. So this is called opportunity screening. And in the clinic, if somebody comes, even the attenders, you check the blood pressure and you will get more patients. Now, before I ask all questions, I'll go to the chat box where a lot of questions waiting there. Chandrasekhar is asking, if I take alcohol at office evening meetings, he says, if I take alcohol, not he wants to say, if somebody takes alcohol at evening meetings, should I skip BP tablets? Any one of you?
No. One
I-
word,
I-
no.
Yeah, I don't know whether skipping BP medicine is required. And first of all, normally BP, if it is a single pill, normally I still stick to the morning. Those Spanish study has said probably evening or night is better, but there's not yet, well supported by the other researchers. So if it is a single pill morning, if at all there is an opportunity for you to take drinks in the evening, you can prepone if your second dose of medicine, if at all second pill, in the afternoon or about evening, 4, 5 o'clock. Or you can take a little later, I think. I don't think absorption, effect-wise, there should not be major difference. But drug absorption also not a major thing. What do you say, Prabhakar? You have anything to say? I don't think a major problem, I think.
Sir,
No,
I
only-
don't think
Only thing, if you take alcohol,
Yeah,
you will forget to take medicine.
yeah.
That's the
yeah,
only thing.
that is true.
You know, I always say, when you give medicine with love and care, it is called Medicare.
yeah.
When you take medicine without anything, it is called medicine. So it is medicine. So some people take medicine and we always have to give Medicare. Now the second question, the Prabhakar, for you.
If you take it with alcohol,
Then
you
also-
get the love and the care both together. sir.
Okay,
Yeah.
Meghanathan again is asking estimation of upper lipoprotein versus conventional lipid profile in primary care setup in a village. I don't know, this is not relevant to our topic, but still being a Prabhakar.
Just
Yeah.
one line on that, sir.
Yeah.
Apolipoprotein B has been proven to be superior to non-HDL cholesterol and LDL cholesterol, both in primary and secondary prevention. So
Yeah,
if you're
because-
given a chance to measure one thing, go for apolipoprotein B.
But in the
Yes, sir.
village,
But again, Prabhakar,
small town.
village,
Sir, he
again,
asked,
Prabhakar, village and all,
Sir.
probably I would say just to get the at least one lipid profile. I agree with because
sir, I
definitely-
agree with that
I agree.
question. So his question,
theoretically,
if he's got a
theoretically fine,
facility,
but
if he's
if
got
he's
a facility, it is
yeah.
possible.
Even
If not-
FOB, even in the cities, we are very, very sparingly used. We use more of a non-HDL as a surrogate marker of FOB. I think,
Non-HDL
if you-
is called
yeah,
poor man's
yeah,
apolipoprotein.
poor means FOB, it's like a surrogate or whatever you can say, poor man's. So I personally feel at the primary care level, if you're in a village or a rural area, just do one lipid profile. If at all, extended lipid profile, if you can do LPA, it is possible, it's fine. Otherwise, just do the lipid level, lipid profile, yeah.
Yeah, because having said this message, when somebody wants to do lipid profile for the first time, kindly include lipid A, LPA, especially
Yeah,
for
yeah.
Indians.
Yeah,
If you include, it'd be good. That's a good message.
yeah.
Now
yeah.
coming to the Rajshekhar, my friend from Europe, role of clonidine, when, where, how long, caution to be observed, sir. Role of clonidine. Anybody, Prabhakar or?
Because you are using, I use only moxidine nowadays, not the clonidine. Yeah, I
But,
don't.
sir, Sir, moxidine is not that effective as clonidine. If you say the efficacy and the effectiveness, clonidine is much better than the moxidine. I mean, moxidine has got less side effects, no dryness of mouth, no bradycardia, and all. But side effects is less, effect also is less.
Yeah.
Okay.
I'll take that question a little differently, sir. Actually, he
Yeah.
himself has asked another question down the line saying
Yeah.
that moxonidine is not effective. Okay,
Okay.
Rajshekhar has asked a question. No,
Okay.
that is true. But the point is, all the side effects are less with moxonidine with a little bit of lesser efficacy. But you must
Yeah.
use it in 0.3 milligram twice a day. Don't go as far as possible more than 0.6 milligrams. But
Yeah.
clonidine, if you do, you must understand there is a very prominent rebound effect.
Yeah.
Rebound is especially prominent if you're combining it with a beta blocker.
Yeah, and the bradycardia will be more if you take with the beta blocker. Bradycardia also will be more.
Very, very careful withdrawing clonidine. So you have to be very careful. You can use it in resistant hypertension, sir. It is a very effective drug when nothing else works. But what I have noticed is that my last line of therapy in all these people is minoxidil.
Okay.
Absolutely wonderful. Bringing down
Minoxidil.
Minoxidil, sir.
Yeah, especially people like me who was a little bit bald, taking minoxidil, you can now expect some hair growth also as side effect.
But what happens to the ladies, sir?
Ladies also, they should not develop face hair, but they can develop a head hair. Okay, now coming to the Natarajan, chlorthalidone induced hyponatremia in elderly. Chlorthalidone induced hyponatremia.
No, you see, generally now chlorthalidone we use more of on 6.25 milligram, and 12.5 very, very less we use in hypertension management generally. And if you see the combination therapy, most of the companies have 6.25 is easily available, 12.5 sometime. But a frail patient, thin, like intake is low, can occur. I'm not saying that it cannot, but I think 6.25 should be okay. If it is 12.5 hyponatremia, we have to take care of, like we have to see that the dose is adjusted, etc. But in elderly people, again, diuretic is one of the drugs for hypertension.
But only thing, in the summer, you should be more careful, especially in elderly person.
I agree with
you. You have to
agree with you. In general, diuretic in summertime in our patient is very important, particularly when they're sweating. Using more frail, elderly, and intake is not good. We have to be careful. I agree with
also data to say that with an ARB like that is available, that is olmesartan and the azilsartan, 6.25 is as effective as 12.5.
Yeah.
Okay. And now coming to the Rangarajan, how will you treat isolated diastolic hypertension patient with 120/95?
Yeah, that's actually the important. Actually, we are ignoring that concept. Actually, it is less than 40. Generally, the diastolic between 40-60 is supposed to be both systolic and diastolic. And beyond age of 60, generally we have isolated. That is Western sort of a definition. But in our patient, maybe little younger age, we can take 10 years younger. So here again, we need to use drug. This is common in young age due to the increase in the vascular resistance. Again, it comes to the same standard drug, whatever we are using. CCB will be ideal drug, and now with the long acting and the newer one we can use. Even for that matter, ARB should be okay. And if a young guy with a lot of tachycardia is the beta blocker. One thing about the tachycardia, when you said about the INDIA-ART study, I don't know whether you were part of it. In the INDIA-ART study, where one of the pharma companies, an 18,000 patient, large epidemiological study from India, maybe one of the largest in the world, where in hypertension, we found tachycardia is one of the important things, heart rate, resting heart rate found around 82 or so. And the evening blood pressure used to be higher than the morning. Then that is also one of the reasons why beta blocker is supposed to be one of the important drug for Indian hypertension, because of this tachycardia, resting heart rate being higher and things like that,
Yeah. I will just go through 2 slides because WHO, protocol, why we follow. It's called HEARTS program of the WHO. What do you mean by HEARTS? HEARTS is healthy lifestyle counseling. E is evidence-based treatment protocols. A is access to essential medication technology. T is team-based care, and S for systems for monitoring. This is the WHO protocol which we follow, and this is the Telangana protocol. What I was talking in the government sector, because I am one of the consultants there. Many states they have started with the state government, central government, ICMR, WHO. We go there and then we call eminent people like you and do a brainstorming. They select 3 drugs, whatever they select. So the people who have selected amlodipine first 5 milligram, then increase to 10 milligram, then telmisartan 40, 80, and then chlorthalidone. This is Telangana protocol. Whereas in Punjab, it's other way about. Amlodipine 5, telmisartan 40, telmisartan 80, then amlodipine 10. So depending on the people we do, actually the global concept, if you see, USA is only 59 and Canada is 68%. Japan also 25%, globally 14%. So India is less than 10%. And the therapeutic inertia we have mentioned. And already Prabhakar has mentioned what are the important things. Just to reinstate these things, I just wanted to show this. And why use protocol? Because the best health system use standardized treatment protocols to improve quality. Kaiser Permanente and US Veteran Administration. That is why simpler protocols are more likely to be used correctly. So all the protocols suggested, which were already said, fixed drug combination, prevention of hypertension. That's again, you have to start talk about WHO. Prevention of hypertension, that is fat reducing, salt reducing, avoid tobacco, heart healthy diet, fruits, regular exercise, and things like that. So these are the important things that important, but still lifestyle management is not a replacement treatment for hypertension. Insisting on patient lifestyle changes before starting treatment is rarely effective and usually results in loss of patients to further treatment. So therapeutic inertia, we have already said. Borderline hypertension, if it is borderline, please treat aggressively. Don't say borderline and keep it, because lower is better. You have given all the points. And medication adverse effects also we have said. So you have to titrate and control. One thing about hypertension and COVID, hypertension increases the risk of severe COVID. So controlling of hypertension is also important in COVID times. And hospitalized COVID-19 patients with overall hypertension rates had been unclear if this relationship was casual or confounded by age and other comorbidities. This I thought WHO has specifically said. Pregnancy hypertension we already said. So I think we have covered all the important points in WHO guidelines. Now I'll come to the panelists for their comments, because there are some questions which are not relevant to our subject now today, because next week we are answering those questions. Now, final comment from you, Sadanand. Sir, what is your final take-home message for hypertension in general?
Can you stop screen sharing so that we can see each other? Yeah.
Okay. Yes.
No, I think very nice, nice, simple. The algorithm like what Dr. Prabhakar showed, the WHO. I concur with the sort of the approach what has been suggested for diagnosing and initiating treatment at what level and what target we should achieve in general population versus the high risk. And as I mentioned earlier also, Indian patients, particularly younger people, along with the blood pressure, whenever we make a diagnosis, at least rule out diabetes, dyslipidemia, weight management, etc., and the habits like tobacco, things like that, rather than just taking BP reading as the only sole factor and saying he has no comorbidity, which is not correct according to me. Like I would always like whatever baseline lipid profile, the lipid abnormality is so common, getting triglyceride, getting the LDL target, etc. So therefore, it is important for us to diagnose all lifestyle disease at one time. Hypertension you diagnose, rule out diabetes, pre-diabetes, and one thing which again you mentioned, borderline hypertension, means the pre-hypertension. Therefore, the JNC7, I like that because that pre-hypertension were removed. JNC8 and the other is removed, which is bad according to me. Pre-hypertension, pre-cancer, pre-diabetes, that word has to be there in the diagnosis, because that again gives a scare, because that improves the adherence and diagnosis. We have to tell the patient you are a pre-hypertensive, you are potentially hypertensive. Like when you do the treadmill, hypertensive response, you are a pre-hypertensive. When you come to clinic, pressure goes up. That means again you are going to get the hypertension in future like that. So pre-hypertension is important concept, and we should keep that word in our usage. Though the guideline, let them not put it. Whether WHO, Indian guideline, or the JNC8, ESC, NICE guideline, nowhere it is there. After JNC7, everything is removed that. To me, this pre-hypertension, like pre-heart failure, that's why I said stage A and stage B is easily treated, like by diagnosing hypertension, diabetes, etc. So that patient going into stage C, stage D of heart failure can be easily prevented. So overall, the approach is fine, simple. At the community, at the primary care, it is quite easy to practice. We have to also emphasize on adherence to the therapy. And I would personally feel, because for us, giving time is a problem, like as Dr. Muruganathan always is in the limelight of hypertension management, educator, simple nurse educator, a health educator, we can tell them once what is to be done. They should, spend time with the patient. I personally feel, we need to spend time with the patient for any care. Unless you spend time just writing, we are busy in our clinic, Like we are treating hypertension, we are treating heart failure, we are doing angiography also, we are doing angioplasty also, where there is a time for us. So this has to be done like, the community level by, educator, maybe nurse educator, health educator, maybe, regularly give them the health advisor, because lifestyle, I think, is an important part. And we doctors also should be like a model for the patient. Like we also should be a model, like, how you are fit, how you keep yourself, things like that. So that will go a long way. And everything we have to give the figure to patient when they come for follow. What is their weight? What is the pressure level? What is their sugar? What is the lipid? Like, simple thing to see what is their risk for the future. Like that will make, patient also, the improve the lifestyle, etc. Like when we see follow patient, now say weight last time, now you are reduced, your pressure is perfect 130/80, your sugar is fine, your lipid level is fine, like that. So everything that this should be there to prevent overall, the burden of cardiovascular disease. Hypertension is one of the tip of an iceberg, but we are talking about cardiovascular disease, and this will be a better approach, better way of, the prevention, like a preventive and treating a hypertension. As we discussed in the past also, family doctor can be a hypertension specialist, and postgraduate can be hypertensionologist. You know that two terminology you have only put. I don't know what happened in the national diplomat, whether this our I don't know, Sangram, or who was there with the DNB, our national diploma. He was there in one of our program, and
Dr. Abhijit Singh was there, and we are
and then he
promoting
was
that.
promoting that in even the sort of, the qualification, the national diplomat, whether hypertensionologist, hypertensionist, like that. We need, because as you said rightly, 200 million, and plus, pre-hypertensive more, diabetes just 50, see 4 times, and 1 in 3, every patient is hypertensive. It's a huge problem. So I must say that we have to prevent, diagnose early, cumulative damage of hypertension should be taken care, early treatment and aggressive management. And
Thank you, Sadanand. As Prabhakar said, I agree with Prabhakar. What Prabhakar said in 40 minutes, with your experience, you put it in a nutshell what anybody should do, and you focus on preventive cardiology. Thank you, Sadanand, for your participation. And as usual, you rock the game, and we'll come back to you. And now, Meenakshi Bhattacharya, before I call Prabhakar, Meenakshi Bhattacharya, are you there, Meenakshi? The Meenakshi Bhattacharya is a professor of medicine. He's a professor of medicine from Aurangabad, and she's also our family. Any comment you want to make, Meenakshi, because you're treating day in and day out hypertension? Any particular point you want to say?
Sir, it is excellent presentation by both the speakers. Sir, just one thing, that whenever a patient of hypertension, diabetes, or any non-comorbid patient is coming to us, we should look for adherence and concordance also, because as sir mentioned in his presentation, that if we use a single pill, that increases adherence or that increases compliance. But compliance is, there is the difference between compliance and adherence is that if someone is taking medicines properly as per the prescription of a doctor, that is compliance. But if the prescription is followed with all the requirements of that particular prescription, that if it is taken with other drugs, like drug-drug interactions, that should be taken care of. Whether it is taken with food, the amount of, or the concentration of that drug in blood, is it changing with food? So taking medicine at particular time for 24 hours, if someone is taking medicine at 9 o'clock in the morning, should be taken at 9 o'clock every day. Then it has to be the drug-drug interaction should be looked after when we prescribe a drug, because many of these patients, they have multiple diseases. So this should be looked after for adherence of the medication. So along with compliance, adherence should also be looked after. That's what, sir. Thank you so much.
Thank you, Meenakshi.
Thank you, sir.
And as Sangram every time used to say, whatever modern treatment and whatever thing, clinical examination is very important. History is very important, and we should not forget whatever guidelines you follow. proper clinical examination and proper clinical history. Sangram, on behalf of you, I've already spoken. Now
Yes.
go over to Prabhakar for concluding remarks. It's already 10:40, so that's why I want to rush up because, yes, please, Prabhakar.
First of all, thanks to all of you for excellent inputs. We were discussing only about hypertension and WHO's guideline for hypertension. So if you want me to summarize this, I think we should remember very simple 140/90 for everybody. Start treating them. High risk patients, diabetics, chronic kidney disease, 130 systolics is both where you start and finish your treatment. RAS inhibitors are going to be the drug of choice. But as age advances, the renin activity comes down. That is the reason why we are looking at calcium channel blockers and diuretics in the elderly patients. So you know your choice of drugs, preferably these drugs, specific indications for beta blockers. In India, like Dr. Sadanand was clearly saying, there is a more interesting indication because of heart rate is a very important determinant of longevity. If your heart rate is higher, you seem to be surviving less. So you should bring down the heart rate. Simplest methods, non-pharmacological measures like yoga also significantly help. It's now accepted as a modality. Don't forget lifestyle modification at any point. Another important point is please look at the potassium. Potassium is a very important component of hypertension. And if your potassium is less than 4.5, most of these patients respond to MRAs. Be a little cautious about that. I think ultimately we should remember when you see a patient, don't delay treatment, start him probably on a single pill, 2-drug therapy because he may not come back to you for a very long time because he's going to be asymptomatic. At least he will have his BP under control, 20 millimeter reduction. Because 20/10 millimeter reduction of blood pressure reduces 50% of the adverse effects, even if you don't reach a target. That's very, very important. And I think with that, I will say thanks to Dr. Muruganathan sir for this excellent opportunity and excellent discussion with Dr. Sadanand.
Yeah, and final conclusion, combination therapy is coming now in various forms. Even for resistant hypertension, recently I saw a paper, SGLT with finerenone, supposed to be good. They've said, a lot of studies in Asian studies, SGLT with finerenone, where you need not worry about potassium because both of them will take care of the potassium problem also. Okay, thanks, Sangram. Thank you, Sadanand Sethi. Thank you,
Okay.
Meenakshi.
Okay.
And I thank all the participants, and we look forward to have you for the next program, which is again private sector involvement. I think all of you must participate and then share your views how to have the private sector involvement for the control of hypertension. Though this topic looks little dry, it's going to be very interesting because every one of you can chip in and help us how to improve the hypertension control, right? Because 70% of the patients are treated by private sector. And I am going to be the speaker. Sangram Bradar is going to be the moderator, and I'm getting the ICMR Prabdip Kaur as the panelist. So Prabhakar and Sadanand said you can also give some inputs as how we can involve the private sector to make sure the hypertension control in India or the whole globe is better.
When is this?
Next Friday, again 9 to 10:30.
9 to 10. Okay.
Yeah, every Friday we have, and the next
Okay.
Friday we have adherence and concordance of hypertension.
Okay.
We are taking some topics which are not normally discussed elsewhere. So
Okay.
that this is very important because you yourself said adherence is important. Prabhakar gave 3 slides on adherence. I took the photo snapshot of Prabhakar's slides also because this is very important. So I think we need more inputs from people like you, and it'll be very good. I thank Anupam and I thank the World Lung Foundation South Asia branch for giving us this opportunity to do this. And this program is in the Facebook Live. And also, if somebody wants, we can send the records also. So many people said Prabhakar's slides are excellent. They want to share the slides. Don't worry, the slides are there. You can take from the Facebook website or from our website, or we can give you the link also for in 2 days time.
Okay.
So you want to say something, Sadanand? You were saying something.
No, I think it's okay. You are doing such a great work. What can I tell you?
Yes, sir. Yes, sir. Yes, sir.
It's a
Yes, sir.
salute to you. And
Yeah,
good
thank you.
Thank you.
Thank you very much, sir.
Thank you, sir. Thank you.
Thank you,
Thank
sir.
you.
Good night. Good night.
Thank you, Garima. Thank you, Sangram. Thank you,
Thank you, sir. Good
Mega.
night.
Thank you. Good night.
Thank
Good night.
you. Thank you so
Thank you,
much. sir.
Prabhakar. Thank you.
Thanks,
Thank
sir.
you.
Good night, sir. Good night, everybody.
Thank you,
Thank you,
Prabhakar.
sir. Thank you, sir.
Good night, sir. Good night.
Prabhakar, your costume also looks very handsome. You look very handsome, Prabhakar.
All inspiration from you, sir.
Good, sir. Nice, nice.
Good night,
Thank
sir.
you.
Good night, sir.
Good night. Good night.
Good night. Good night to all. Good night to all.
Good night.
Bye-bye.
Bye.